Welcome to the Hayes webinar entitled The ROI of Evidence. I'd like to introduce Dr. Keith Fernandez, who's the President and Physician-in-Chief at Memorial Hermann. Today, he's going to be talking to you about their journey and how evidence has made a difference, particularly in talking about the return on investment. So Keith, over to you.
All right, thanks, and hello everybody. I basically am the chief physician of a fairly large IPA in Houston, Texas. This is our annual report, and I'm going to introduce you a little bit to the company and to how we have our doctors collaborate with us. But I'll try to be fairly brief with that so we can get to the actual meat of the presentation. But we have a strategic vision that really is a fairly simple one, easily accomplished, I think. It's to entirely transform the practice of medicine in Houston, and collaborating with patients, payers, caregivers, physicians, anybody who actually wants to collaborate, we're going to do that. A primary foundational process here is the use of evidence-based medicine. This is really the core concept of our company to define how we're going to do that. And we have a culture of physician accountability and core values also of quality, safety, and cost efficiency. And our long-term goal, I think most of us probably have similar long-term goals, is to be able to take care of populations of people cost effectively. So I'll talk a little bit about us, give you an overview of Memorial Hermann, clinical integration, and how we've established governance in quality and safety in our hospital system through what we call our clinical programs committees using evidence-based medicine. So I won't go through all the details here. We're a fairly large healthcare system in Houston. We're not located outside of Houston. We have multiple hospitals and specialty programs and the busiest trauma program in the country. We've won a lot of awards, and these are very nice to display to groups. They show that we've done some things very well. I think none of us here at Memorial Hermann are resting on these accomplishments. We think that's nice. We think we've got a lot of work to do to get better and really to produce high-quality outcomes. As you know, many of these awards are based on reporting metrics and core measures, but not all of them have any real proven effect on outcomes. We're rapidly moving our healthcare system to produce the best outcomes. Our program overall has about 2,000 physicians in the clinically integrated model. We have 3,500 total physicians. About 2/3 of them are specialists, 1/3 primary care doctors. We have APCPs, which are advanced primary care practice physicians. These are basically patient-centered medical home physicians. And we have a relatively small number of employed physicians, about 100 primary care doctors. So we're working here with a model that emphasizes the participation of private practice physicians in our quality and efficiency enterprise. We bring value to these physicians in a variety of ways. We produce bonuses for them based on cost reductions and quality. Now, something we call the MHMD University to develop physician leaders. But really what we allow these private practice doctors is the ability to control their lives going into the future, to define what quality is and how it should be implemented, same with cost efficiency, so that this is not really driven by the hospital system, but it's driven by our physicians. They actually have the ability to affect their practice both in and outside the hospital, and they've become very accountable in this process. It is a remarkable thing to me to watch our physicians working together to produce higher quality and cost efficiency. I will not go through this slide in any length. Let me go to this. We all know about this, and I'll spend just a minute or two, that healthcare is in crisis. The concept that we have to do something different than we've done in the past is, I think, obvious to us all. We have all sorts of age-related diseases that are really drowning us. and they're just becoming more and more common as we get older. People who pay for health care want a shift to prevention and wellness, population management. I don't think they really understand how we can accomplish that, and I don't think anybody has really figured it completely out, but we're trying to. Lots of new technology that may change the way we practice, a lot of stuff that Hayes is very close to in genetic technology, and we actually now are able to influence how benefits are designed for some of the employers we work with that may change the way we practice as well. And then I'm going to spend just a minute on this. We all hear about lots of waste, and the waste is in every aspect of medicine, in the hospitals, in doctors' offices, in just virtually every aspect of medicine. I call this process here empowered autonomy, and this is physicians who ask for things that are unproven, that are interesting, might be fun, might be better, but really there's no evidence suggesting that, and historically they've been allowed to do whatever they want. And in fact, even in our healthcare system, there are times when this physician autonomy and power trumps some of the things we're trying to do. I think the old model of, what do you want in your hospital? You want more doctors, more tests, more procedures, is rapidly going away. Lots of duplication of tests, lots of unnecessary tests. We financially reimburse and promote unnecessary testing. Lots of medications with high cost and questionable utility. The culture in Houston in particular is very much like the Old West, I think. We are, by and large, a lot of doctors who like to operate independently. About 1,900 of our clinically integrated doctors are in private practice. The practice size averages somewhere around 2.2 now. In Texas, we have a very definitive culture that includes a particular kind of diet. We have more restaurants per capita than anybody in the United States now, and that number's just growing. Here, as in many other areas, we have not done very well with palliative care or end-of-life care. We all know there's a huge amount of stress on both individuals and systems. And then most importantly for us, the healthcare system is in fact not a system that produces health. I think it's an important concept, and really I think points to the importance of beginning to look at evidence in what works and what doesn't work all across the healthcare system, not just in equipment that we buy or medications, but in every process that we look at. From, is care management, the way it's being done, really effective? I would argue that it probably isn't. Insurance companies doing care management generally, I think, is much less effective than physicians doing care management. But this system basically is a very good model for paying people. And in a system that is designed to pay people, what you get is a lot of payments. So the people involved in it are looking how to get payments, not how to make people healthy. So incentives aren't aligned. The other thing I'll say, and I think this is a really important part of the advantage of a company like Hayes, and that evidence really is in the eyes of the beholder sometimes. You can look at the same evidence from different perspectives and come up with completely different conclusions. We all should be striving for this very simple triple aim. It's reducing per capita costs, better care for individuals, and then population management. And just briefly on this slide, moving away from all of these things I've just talked about, unnecessary tests and inefficiencies, to really a highly valuable healthcare system. This is a slide that just indicates that we have an accountable care organization both in Medicare and on the commercial side, and that changing the way we practice is absolutely critical to the functioning of this accountable care organization. We can't just have the name of accountable care. We actually have to do accountable care. And again, for that purpose, we need a very strong program. So this is what I was talking about a minute ago, is evidence and the problems with evidence when you try to get it yourself. First of all, you've got to be pretty good at finding evidence if you want to look at it. I spent about 40 hours of my time investigating platelet gel, the second thing on the list here, and came to the conclusion that it really doesn't have any utility in operative inpatient procedures, like a lot of our doctors claimed. Now, I could have and tried at that time to look it up on the internet, and I found a company that produced something on that, and that was Hayes, but I couldn't get the information unless I talked to them. And that actually led to the relationship that we have evolving with Hayes right now, because eventually when I talked to them, got to look at their product, I thought, man, oh man, this could really help us. We'll get into that a little bit more. As you know, evidence nowadays may be directed by marketing, and my example there is proton pump inhibitors. The companies that make proton pump inhibitors design their drugs based on marketing evidence. So they'll actually design a research trial that, if you don't know a lot about it, looks pretty good, but indicates that their drug is much better in some particular area that may or may not be important actually to the care of a patient. They do this to be able to sell the drug and to sell it at a higher rate. I don't know if you all know, but when omeprazole and Nexium, what's commonly known as Nexium, which is esomeprazole, came out, they're isomeric drugs. They're basically mirror images. And all the initial research done by that company used twice the dose of the new drug, Nexium, compared to a half dose of the old drug, Prilosec. And oddly enough, the research showed that Nexium was a little bit better. It was about 7 or 8% better in suppressing acid. Clinically, not that significant, but Nexium is one of the biggest selling drugs ever in history. Research is directed by special interests. The companies that own some of these products, like platelet gel, design the research products, the research projects, and then publish that data. Sometimes very hard to tell how they have bent the evidence, but they often have. There are perceived biases. This next one is a recent one brought up by my orthopedic committee. One of the major orthopedic societies in the United States recommended against the use of hyaluronic acid injections for joint pain in favor of joint replacement. Now, there may be a great deal of evidence supporting that. On the other hand, I look at an orthopedic society looking out for the interests of orthopedic doctors and think, boy, we're going to switch to joint replacement on all these patients. In fact, that may be the right thing to do, but without a really independent view of the evidence, in other words, one that is not based on an orthopedic society or the makers of this HA or the producers of joints, it'd be very hard to tell. Expert opinion often has nothing to do with evidence. It's important, don't get me wrong, and I follow expert opinion quite frequently, but it certainly isn't evidence. This is very common in EGD, the upper endoscopy, and the use for the use in patients with acid reflux. Expert opinion varies from it really doesn't need to be done unless there are really serious warning symptoms to it should be done in every male over 50 who has any acid reflux. And then I'll tell you another brief story where I think evidence is critical, and we used Hayes in this regard, but if you've heard of Lifeline Screening, it's a company that goes around selling a certain number of screening tests for somewhere near $200. They often affiliate with hospitals, and I was disturbed that this company was affiliating with Memorial Hermann and actually using our name. There was no financial transaction here, but there was a transaction in that they got to use the Memorial Hermann name. My physicians told me that the Lifeline screening tools did not have evidence, and then we actually did some significant research, including Hayes, that supported that notion, and that company actually came here to change my mind and had very little evidence to support the use of their stuff. They had very emotional evidence, which they frankly told me I didn't care about people having strokes, and that's why I didn't think these tests were any good. But it's sure nice to be able to think that that's not true and that I actually have evidence for what I think. And then, of course, there is no evidence for much of what we do. A lot of this is hand-me-down knowledge coming doctor to doctor that really doesn't have a basis in evidence. So I'm going to tell you a little bit about how we've put this together, but we are a clinically integrated network. As you can see, the very first thing on my list here is that we're determined to practice evidence-based medicine. We're accountable, and we are trying to improve the health care both inside hospitals and outside hospitals. To do this successfully, we all need lots of information technology, and we have implemented a huge amount of this at Memorial Hermann. We're not anywhere near done, but I wanted to show you that it helps us drive our programs. And we have a relationship with our physicians that I think has really blossomed. We have an evolving private practice culture because of the way we interact with our physicians. We basically promise to always watch out for their interests. Now, never at the expense of a patient. And we believe watching out for their interests means watching out for all the people in the healthcare system's interests, because we need all components of this process working together. They also, again, you'll look at the very top here of our compact, and it says the physicians agree to practice evidence-based medicine, a critical component to these programs. This is how we actually implement it. This is the clinical programs committees. These are about 27 different committees involving specialties or joint operating committees surrounding specific problems we have in our hospitals or in our outpatient environment. There are about 700 of our 2,000 doctors who are participating in these committees by actually attending meetings that occur anywhere from monthly to quarterly. They have become really dramatic, important leaders in the evolution of healthcare here in our hospital system. And part of that is that we provide them an environment to evaluate evidence, to talk with each other outside of the hubbub of the day. We put them in a room and put in some assistants, nurses, care management people, pharmacists, and ask the doctors to help us solve problems. We also tell them to come up with the problems that we need to solve so that we're not just addressing what we perceive to be important concerns. And one of the things that happened to us is that a couple of years ago, our system board and its quality committee decided that the work we were doing was so important to healthcare in our hospital system that they gave us basically direct authority to produce quality protocols, order sets, guidelines, and to define how we were going to approach that in our healthcare system. We do this because we have 9 hospitals and 9 medical executive committees, which can be quite disagreeable when you're trying to change local practice. By giving us authority to do this and send letters like this, and this is a letter from our chairman of the System Quality Committee and myself to our hospital MECs saying we think you should be doing something that is based in evidence and that will improve the quality and safety of the hospital, and we want you to actually vote this up or down. Instead of just making a recommendation and letting them either speak to it or not speak to it, we push them to make a vote. And now, when they do make a vote, when they do make a vote, about 95% of the time it's in agreement with our recommendations. About 5% of the time it isn't, and then we go back to the drawing board on those 5%. And we also will bring in the CEO and the chief of staff of that hospital to discuss this with our board, mostly oilmen and bankers and the president of the Houston Zoo, people who really take quality in our hospitals very, very seriously. And most often the arguments against doing what we ask them to do are lost. So these are some of the things that they produce, and this is all using evidence, allowing the physicians to look at the evidence in a cohesive, coherent way, and then making important decisions. They recommended a number of different things based on evidence. They made a CME on DVT mandatory. They recommended changes to our electronic medical record to make use of a DVT advisor mandatory. And they went through this kind of stuff. Can you believe this? This is all derived from physicians using evidence about what to do and not to do. You shouldn't be looking at the detail here, but you can see that there is a huge amount of detail. And there's evidence on every one of these points that they had to investigate. You can imagine if they had to do this on their own, it would have taken them months and months. This project, start to finish, took us about 4 months. And it led to this. This is fairly difficult to read, but if you look at the blue box at the bottom of this slide and move from left to right and go to 10th, that means we're in the top 10% in the United States in the prevention of venous thromboembolism, or DVT. This was the first hospital to follow all of the recommendations of our task force, and you can see they rarely have a DVT at that hospital. Previously, they had quite a few. So it's taking evidence, filtering it through physicians, implementing the recommendations, and changing what happens to real people in our hospitals. Is that cost effective? Yes. These DVTs and VTEs are hugely expensive, and I've seen values for them as low as $17,000 up to $170,000 in the additional cost. That depends on if it's a DVT or a central thromboembolism. We give out awards for this stuff now when the doctors get together. They can win these impact awards. These are anywhere from $10,000 to $2,500. It's very interesting to me. This money can be used for anything. Our physicians uniformly pour it back into getting more help, research assistants, analysts, and remember, these are private practice doctors. They're not, largely university-trained doctors or employed doctors. So here's a few other places where we have made a big difference, I think. Our trauma CPC looked at evidence surrounding the use of oral contrast with CT scan. This is not a huge expense as far as the contrast goes, but the evidence doesn't support using it in trauma patients in any case. The committee recommended not using it. We have had a fairly dramatic turnaround time for trauma patients in our emergency rooms, and again leading to certainly much happier patients and some cost improvement just from turnaround time improvement. This is the platelet gel. Platelet gel was costing our healthcare system $2 million a year. It is basically not paid for by insurance companies or Medicare. The evidence is in fact very strong that it doesn't help. Expert opinion was very light, so the experts didn't say don't use it, it doesn't work. They would say, well, if you use it, explain to the patient that we're not sure if it works or not. And much of the platelet gel in use was funded with a significant conflict of interest with the actual physicians who used it. For one thing, they get paid for administering platelet gel, even if the hospital doesn't get paid for the platelet gel. So we removed this platelet gel from the formulary based on recommendations from our orthopedic CPC and our supervisory large CPC, resulting in really an immediate drop in expenditures of about $2 million a year. We do other things. We have significant programs surrounding internal evidence on order set usage. We've been able to increase the electronic order set usage across the healthcare system fairly dramatically. We do bonus our doctors based on the percentage of use by hospital, not by doctor, but the whole hospital has to get up to snuff. Our own evidence showed that it was about $1 million cheaper per year in risk-adjusted cases using our order sets over our largest DRGs, our 6 largest DRGs. The next slide, or the next thing here on this program, our inpatient quality and safety program, iatrogenic pneumothorax. We used evidence that ultrasound for central line placement dramatically reduces the incidence of that complication. We implemented it. We didn't just say everybody do it. We actually provided the ultrasound equipment, made sure it was available, and we had extensive training in the use of the ultrasound equipment and have dropped pneumothorax significantly. I already told you about DVT. We're doing the same thing with hospital-acquired infections, and I'll show you some data related to that. This is what our slide that talks about when zero is a good thing, and what we've done with some of those things I talked about. This was our first hospital to follow our ultrasound recommendation for the prevention of pneumothorax. This hospital got out to 3 years without a pneumothorax before they had one, and that was one that they used an ultrasound on and still had the pneumothorax. This is the same hospital, and just showing you what happened, ultrasound used, and then no more pneumothoraxes. Now this is an adult ICU in our system with no central line associated bloodstream infections. The protocol here, which was very clear in the evidence but not used very much, was total body draping for central line placement and absolute sterility. This still can be done in a regular room or in an ICU, but otherwise the procedure has to be done just like an operation. And we've eliminated central line infections in a number of our hospitals, and sometimes over our 9-hospital system don't have any central line infection for a month or longer. Our tier hospital, which is our rehabilitation hospital, implemented a number of evidence-based protocols surrounding things like falls, ventilator-associated pneumonias, central line infections, etc. And this actually went out another 6 months before they had any serious safety event. This is a neurologic rehab hospital that took care of Gabby Gifford, if you'll recall, the congresswoman who was shot. And they didn't have any falls for a year and a half, no bed sores, no central line infections, no ventilator-associated pneumonias, nothing. A remarkable use of evidence-based guidelines. Here is our system, the 9-hospital system, central line infection metrics, and you can see that over the years we've been dropping this very dramatically, and now into 2012 and 13 we have stretches of many months without any central line infection. Here's a neonatal ICU with the same process, and you can almost, I don't show them on this slide, but you can measure this out by when we implemented different evidence-based protocols. Ventilator-associated pneumonias, this is the entire system again. Again, we go months without any ventilator-associated pneumonia in the system by following very strict evidence-based protocols surrounding ventilated patients. And we've now given out over 91 of certified zero awards, which are awards which recognize at least 1 year without a certain type of complication. And you can see some of these hospitals, no pressure sores for 5 years, no pneumothorax for 5 years, no retained foreign bodies in surgery for 3 or 4 years. Southeast Hospital, very busy community hospital, no birth traumas for 4 years. We have a number of OB protocols that we use and checklists which have dramatically reduced our neonatal injuries. So I was going to jump, that's a lot of hospital stuff, but we do use evidence in our outpatient clinics as well. We have built a patient-centered medical home using some evidence-based things and some just common sense things. We have patient portals in all of these offices. We have online scheduling. All of our doctors are required to have an EMR. There's something called the point of care tool, which extracts information from the electronic medical record. Very, very important with our ACO, where we're allowed to have no missing metrics. It's 100% reporting. They connect to the Health Information Exchange. They're all moving or are at NCQA Level 3. We have extensive population management now funded and under the leadership of the physician organization to be able to manage our primary care physicians' panels of patients. This is an area where insurance companies don't do very well. They don't get a lot of buy-in. Our start to completion in chronic disease management is upwards of 65% compared to most insurance companies around 25%. Now, this is a huge amount of time and effort and a significant amount of money. And we have been trying to use evidence as much as we can about what works and what doesn't work. We don't want to spend this kind of money without knowing we actually are going to help. We're either going to improve quality and safety or improve cost. So as we approach each one of these, some of them we still don't have evidence on. I have to say, we think it's the right thing to do, but we can't prove it. But much of it we can prove, even to the degree of being able to do different things in the care of diabetic patients. Some care management processes have been shown not to work. They're nice. The patients often feel better, but the outcome, the reduction in complications of diabetes, don't change. And so we want to go down as few of those kind of rabbit trails as we possibly can, and that requires a fairly extensive use of evidence. And then I would say, has it worked? And I think it has. If you look at both our internal data and data now from several large insurance companies involving about 300,000 lives, we are doing better in most things than most people. Most of this is because we have really good doctors, I will say. We've organized them. They are committed to evidence-based medicine generally and are very collaborative with us. So in almost every respect, we're better than our market, which doesn't mean we're better than everybody in the world. I can assure you we still have lots of work to do. But we also can show now that we move people, and this is a relatively complicated slide, but it shows that we're moving people into medium or lower risk categories from the high risk category with significant numbers, basically moving about 1,000 people into the low risk category. This is a population of patients that didn't change. We kept the population constant from year to year. We've assembled, or our physicians have assembled, what we call our measures of excellence, which correspond very well with accountable care metrics to match those up so that every time we negotiate a contract, we try to use the same stuff. I don't know if there's evidence there, but I can almost guarantee it works a lot easier if you only are doing one thing at a time. And let's see here. I think I went through that already. How did that get in there twice? We do a very fancy risk stratification for our populations to know what to do with them, and this has been a huge success. I'm not going to go through that. And then I want to show you, this is our accountable care organization, Medicare. We don't yet advertise it, but this is complete numbers for our first year. We've grown from 21,000 patients to 26 in 2012. We're actually upwards of 40,000 now. Our benchmark expense, for those of you who know, is luckily very high. That gives us a huge ocean to improve in, and we did improve that number significantly over this year. We had a 12% first-year drop. But I think most importantly, by following our evidence-based protocols and guidelines, if you look at our numbers on ambulatory care sensitive conditions, people who have diabetes, COPD, congestive heart failure, our admission rates are much lower, and our readmission rates are much lower. Our utilization is much lower. We have fewer emergency room visits. The only place where we're not doing as well as we'd like is in the use of high-end imaging, and that I think will be changing in the next year. So lots of things. I think the most exciting thing for me, and I think I'll end on this, with the Hayes Company, is my enthusiasm and my physicians' enthusiasm for having evidence at the fingertips. We have historically met in all of our meetings, and it's been a struggle over the years to produce programs rapidly, but by having evidence that we can get really at the time we need it. We can come up with an issue, have the research done, and evidence provided to us that is really non-biased. It's not from the doctors necessarily. It's not from insurance companies. It's not from the hospital system. It's from an outsider who really is just looking at the quality of the evidence. We can have it right there for the doctors to use. A lot more direct production of programs that actually change what we're doing effectively. So we are exploring right now the concept of adding a real live HAES person to our clinical programs committee in a full-time job working with those committees, both to provide evidence but also to look and listen to what the physicians are doing, what they talk about, what's important to them that may not be reflected in the evidence, to be able to produce a very high quality product based on the evidence that we use. So I think it's very clear that this is the kind of thing we need to do to change the way this healthcare system works, producing better outcomes rather than just more money.